Alright. Please join us in the Mill Mountain Conference Room if you're anywhere near the Tanglewood building, and as always, we appreciate you joining us online. Our speaker today is Dr. Dustin Daniel Flannery. He's an attending physician at Children's Hospital of Philadelphia and an assistant professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. He's a recent graduate of the CHOP Pediatric Hospital Epidemiology and Outcome Research Training Program and the Masters of Science in Clinical Epidemiology at the University of Pennsylvania. He received his Bachelor of Science with honors from Virginia Tech. And a Doctor of Osteopathic Medicine degree from Philadelphia College of Osteopathic Medicine. After completing his residency and chief residency in pediatrics at Alfred DuPont Hospital for Children, he completed a fellowship in neonatology, perinatal medicine. His research interests are neonatal infectious diseases and antimicrobial stewardship. Please join me in welcoming Dr. Flannery. We're doing didactics for the residents as well at lunch, so thank you for that as well.
Good morning, thank you so much. Can you hear okay? Great. Thank you so much for having me. It's so great to be back down in Southwest Virginia. I love Roanoke, of course I had to stay in Blacksburg. But it was a very easy and beautiful drive this morning. Today I'll be discussing updates in neonatal early onset sepsis, and I'm hoping that this talk is applicable not just for neonatologists, but also for anyone with an interest in infectious diseases, pharmacy, general pediatrics, hospital pediatrics, and more, and epidemiology. I have no conflicts of interest to disclose. And I always have to start any talk with just identifying and acknowledging my research team. The very top left is Dr. Karen Popolo, who's my research mentor, and right under her is Dr. Jeff Gerber, who is my co-mentor, and then this is our entire research team who makes all of this happen. Outline for today, I'll start by going through some contemporary epidemiology, including the incidence of early onset sepsis, recent microbiology data, just briefly associated outcomes. We'll spend a bulk of time talking about risk assessment, which is something I'm very interested in, how that differs for term infants and preterm infants. How do you decide whether to evaluate a baby for early onset sepsis? And then we'll switch gears and talk about treatment, with a focus on empiric treatment, since that's most of what we do is starting antibiotics when we're worried about infection, but we don't know if it's there. We'll talk briefly about antibiotic resistance, global health threat, how that affects us in the NICU, and then talk a little bit about antibiotic stewardship in the neonatal setting. I have to dedicate this talk to my classmates that were killed in 2007 when I was a senior at Virginia Tech. It was really a nice experience yesterday to be back on campus and visit the memorial. And on a lighter note, just to share some old photos of me as a Hokie. In the middle here is walking through campus one day and seeing a calendar and noticing that I was on it. It's very Virginia Tech. Studying on the drill field with a bike. I think that's August 2006 probably. On the left here is the Marine Corps Marathon, which I ran during my undergrad time. And then over here on the right is McAfee's Knob. I don't know if anybody's been up there on the Appalachian Trail, one of my absolute favorite spots in the world. It's really nice to be back. All right, so let's start off with some contemporary epidemiology. So these are CDC surveillance data from 2005 to 2014, and they demonstrate that the overall incidence of early onset sepsis, and this is for all gestational ages, is about 0.8 cases per 1,000 live births, and this was stable over that 10-year period from 2005 to 2014. Prospective surveillance data from the Neonatal Research Network, or the NRN, which Penn and CHOP are a part of. This was led by Barbara Stoll and looked at incidence data from 2005 to 2017, so more recent. And this showed an incidence of about 1.1 per 1,000 live births there on the left, slightly higher than that CDC estimate, probably because the CDC is more national surveillance, where the NRN is more high-risk centers, perinatal birth centers, level 3 and level 4 units, just 18 centers across the US, so probably just a higher risk center issue. This study did break down the incidence by gestational age, though, And they found that there's a dramatically higher risk for very preterm infants, less than 28 weeks gestation, who had an incidence of almost 14 per 1,000. The study did not break down the estimates more by gestational age, just owing to the numbers. And so because the NRN only includes those 18 high-risk academic centers, we did a study where we teamed up with the Vermont-Oxford Network, or VON, to assess early onset sepsis epidemiology among a larger and more nationally representative cohort, specifically of very preterm infants. And this includes babies at both academic and community hospitals across the US, so more generalizable. And the objectives here were to determine incidence by gestational age week, so not just a broad category, among these very preterm infants, and also to gather some data to help inform empiric antibiotic decisions by determining contemporary microbiology, highlight risk factors, and determine short-term outcomes to help you prognosticate when you have an infant who is infected. So we looked at centers between 2018 and 2019. There were over 750 NICUs from the VON cohort. This includes 49 states and DC. I think maybe Wisconsin's the only state without a center. We looked at infants who were born less than 1,500 grams and or 22 to 29 weeks. And we identified over 84,000 very preterm infants, and 1.4% were diagnosed with culture-confirmed early onset sepsis. We estimated the incidence overall in that yellow bar and found a nearly identical incidence to the NRN data of about 13.5 per 1,000 very preterm infants. But when we broke down further by gestational age weeks, we found really a striking 12-fold difference in the incidence between infants at the highest and lowest gestational ages. And so infants at less than or equal to 23 weeks had an incidence rate of 45 per 1,000, which is quite high and clearly alarming. When we think about the microbiology of early onset sepsis, we immediately think about group B strep and E. coli. These are classic board questions. Usually we think of Listeria also. I've never seen Listeria. It's pretty rare, but it's just pathognomonic, so it ends up on our board exams. But some recent data show that there's really more to the story for early onset sepsis than just group B strep and E. coli, particularly when you look at the differences between term and preterm infections. So from that VON very preterm cohort, about half of early onset infections were caused by E. coli. Remember, these are very preterm infants. And a fifth were caused by group B strep. And this is really congruent with those recent NRN data, which reported E. coli as the now predominant pathogen among preterm infants. Importantly, a third of infections were caused by organisms other than group B strep or E. coli, including an assortment of gram-positive and gram-negative bacteria. So the findings from the VON cohort really solidify the findings from the NRN's EOS2 surveillance work from 2020. Again, group B strep predominates for term infections, and so since there's more term babies than preterm babies, group B strep remains the number one cause. But when you look at preterm infants separately, E. coli is the most common pathogen. And again, in both of these groups, a third of infections are caused by organisms other than
5548546 is not available. At the tone, please record your message. When you've finished recording, you may hang up or press 1 for more options.
So what are those other organisms? These are some data extrapolated from the NRN and VON, and also two of our birth hospitals in Philadelphia. So for gram-positive, Staph aureus is a somewhat common cause, also Enterococcus, other random strep species, including group A strep, and then again, that rare Listeria isolate, remembering that Listeria is a gram-positive. Many studies don't consider coagulase negative staphylococci or cons, things like Staph epidermidis or homidus. We don't usually consider these true pathogens in the early onset period, a little bit different for preterm babies who've been in the NICU for a while. Usually when they have cons identified, it can be an actual pathogen in the late onset setting. There are some data from other countries that are starting to challenge this, including from Asia, India, China, and also in Europe that are starting to suggest that cons may actually be a cause of early onset infection, but I think the jury's still out there. For gram-negatives, Haemophilus, one of the most common that we don't always think about. And then some of the other players like Klebsiella, Enterobacter, Citrobacter, Pseudomonas is pretty rare. Serratia we sometimes see in outbreak settings. And then most of the work I'm presenting today focuses on bacteria, but fungal pathogens, namely Candida species, are well-known opportunistic pathogens among infants born at the lowest gestational ages. And even term infants can be born with congenital Candida infection. I'll just briefly mention clinical characteristics between infants with and without early onset sepsis. I'll admit from the EOS2 study, we didn't learn much new about risk factors for early onset sepsis. Not surprisingly, infected infants are less mature, born smaller, less often delivered by cesarean section, and have longer lengths of stay. And these are all unadjusted analyses. When we did some adjustment looking at differences between infected and uninfected infants, and the difference in survival, for this analysis we adjusted for gestational age, outborn status, sex, small for gestational age, APGAR score, delivery mode, and more. And we found that infected infants were less likely to survive with an adjusted risk ratio of 0.82. So 90% survival in the uninfected group, 68% in the infected group. And while the outcomes for early onset sepsis, usually we think about mortality, our results also suggested that babies who were infected and survived were more likely to have major neonatal morbidities. And these were also adjusted analyses. And the morbidities we looked at were CLD or chronic lung disease, brain injury or IVH, and eye disease or retinopathy of prematurity, ROP. And these three morbidities have all been associated in separate preterm populations with an increased risk of neurodevelopmental impairment and later death. And so while in our data we did not have post-discharge data, this suggests that these babies who get infected and survive are likely at higher risk for impairment down the road. All right, I'm going to switch gears now and talk for a bit about early onset sepsis risk assessment. What I mean by risk assessment is, for any of you who attend deliveries, either in the general pediatric setting or as a neonatologist, for every single newborn born in the United States, you make an active decision about whether or not to start antibiotics because of the risk of sepsis. It's an active decision. We often document it in our H&P. And you do that whether it's a really sick 23-weeker, whether it's a benign late preterm infant, or even whether it's a well-appearing full-term infant. We all actively decide within an hour or two of birth whether this infant needs blood cultures and or antibiotics. But how do you make these decisions? And so this is my son who was born about 2 years ago. And even though he was a healthy term infant, the pediatrician at birth had to decide whether he was at risk of sepsis, even though he looked well. This is good now, much bigger. I want to just do a simple exercise, walk through a clinical vignette to demonstrate how provider variation can impact neonatal care. And so this vignette is actually from a study conducted during a statewide antibiotic stewardship QI collaborative that was aimed at reducing early antibiotic use. And so think about this case. The common characteristics of all three scenarios are an infant born at 38 weeks gestation, delivered by spontaneous vaginal delivery, and admitted to the NICU for continuous monitoring. An initial CBC was normal except for a mild bandemia and a chest radiograph. So I'm going to give you three scenarios that are basically risk factors and infant factors. Case one is an infant born to a mother who's screened negative for group B strep, who was febrile during labor and her rupture of membranes was 28 hours. And at birth the infant was well appearing, but you checked a CRP and it was elevated at 12 hours. Case two is an infant who had no maternal risk factors, uncomplicated pregnancy, no concern for maternal intra-amniotic infection, but the infant at birth had tachypnea and grunting. And case three is an infant who was born to a GBS negative mother who was febrile, ruptured for 28 hours, and the infant has tachypnea and grunting at birth. So case one is basically maternal risk factors in a well-appearing baby. Case two is no risk factors with an ill baby. case 3 is maternal risk factors and an ill baby. And so think for a moment, how would you manage these 3 babies? Would you send blood cultures, start antibiotics? Do you need more time? Do you need more information? Do your birth centers use the sepsis risk calculator? Yes. So you probably just use the sepsis risk calculator now. But before that time, and to really show you why those sort of studies are so important, these were responses from providers in almost 30 NICUs, and they demonstrated significant individual practice variation. So the column on the right is the CU. This is the coefficient of unilikability, and that's defined to mean how often observations differ from one another, where 0 is minimum and 0.5 is maximum variability. And so for cases 1 and 2, 30% would start antibiotics and 70% would not. And for case 3, 80% would start antibiotics and 20% would not. All 3 of these cases had significant variability based on the CU. And so the authors concluded that individual practice variation is a barrier to reducing unnecessary antibiotics in NICUs. And this isn't our fault. We are not trying to do the wrong thing by giving lots of babies antibiotics, but we don't want to miss babies with an infection because we know that can have devastating consequences. And so we need more data and more tools to help us make these decisions. So before we dive into those approaches, I just want to acknowledge what I consider to be the current culture of early onset sepsis risk assessment. And so for term infants, our goal is really to determine out of this sea of newborns who really needs empiric antibiotics. Whereas for preterm infants, the goal is to determine which of these babies can we spare from receiving early antibiotics, given that data show that most preterm infants in the US are started on antibiotics at birth. And if we can't give you a lot of data to help you decide when to not start, can we at least give you some information to help you decide when to stop in the setting of a sterile culture? So the AAP Committee on the Fetus and Newborn, COFIN, released comprehensive early onset sepsis guidelines in 2019 or 18. And they had 2 separate guidelines that look almost identical, but one is for infants above 35 weeks gestation and one is for infants below. And so I'm going to review quickly the statement for 35 weeks and above, the late preterm and term strategy. They basically say that there are 3 approaches you can use, and all may be appropriate depending on your setting. Each approach uses maternal and delivery risk factors, albeit in different ways, to identify infants at increased risk of early onset sepsis. And each approach really has its own merits and limitations. But importantly, no strategy can immediately identify all infants who will develop early onset sepsis at the moment of birth. So we'll never be perfect, at least probably not during my lifetime. And no strategy will avoid some babies getting treated who aren't infected. And so you really just have to try to minimize treatment of uninfected babies and maximize your sensitivity in identifying those at highest risk. And so the first on the left is the categorical approach. This is the approach I grew up with. This is what I used during medical school and residency. And this relies on dichotomous presence of risk factor threshold values. So what do I mean by that? If your risk factor is maternal fever, does the mother have a fever? Yes or no? It's a yes or no question. Same thing for rupture of membranes. Is rupture of membranes greater than 18 hours? Yes or no? So it's really a binary fashion. And the advantage of this approach is it was very familiar for quite a long time. This is what was recommended by the CDC since the 90s. It's been studied extensively. But the limitations include some ambiguity around those risk factors. For instance, 100.3 would not count as a fever, but 100.4 would. And is that clinically really that different? And this approach does lead to pretty widespread use of antibiotics. In some studies, up to 10% of well-appearing term newborns. The second, in the middle here, is the multivariate risk assessment approach. The best example here is the sepsis risk calculator. This is what we're using at my birth hospital. And this basically gives you an individualized synthesis of established risk factors and the clinical condition to estimate a specific baby's risk of early onset sepsis and to actually put a number on it. The best example again here is the sepsis risk calculator, which utilizes predictive models with recommended clinical algorithms, and I'll show you a little bit more about that. The calculator's been prospectively validated and has been shown to decrease antibiotic use among term newborns by up to 50% without short-term safety concerns. So this has been pretty huge. And the third, which I'm less familiar with, is this clinical condition approach. This just relies on serial exams of newborns regardless of what happened during labor and delivery. Do you look well? Then we're not going to start antibiotics. If you don't look well, then we are. And this approach, you have to remember that baby's clinical picture can evolve over time. So if you decide at birth that a baby's well appearing, but then 3 hours later the nurse calls you, the baby's grunting, you're going to have to change that decision and bring that baby to the NICU. And you have to recognize that's not a failure of identification of an infected infant. That's just you adjusting to the data over time. So again, the major limitation with that approach, and why I think it's not done often, is the requirement for structured serial newborn observation, and then rules and evaluation and empiric treatment. So who's watching this baby so closely over the first 24 hours to determine if symptoms develop? Risk assessment for preterm infants, not as robust. In 2017, my mentor, Karen Popolo, and other investigators from the NRN studied this concept of low-risk delivery characteristics. And what they mean by low risk is, given the pathogenesis of early onset sepsis, which is maternal colonization and ascending infection, can you use some birth characteristics to determine which infants could be at lower risk? And what they thought of were things like C-section, rupture of membranes at delivery, and absence of any concern of clinical chorioamnionitis. And so if you have a mom who presents for a repeat C-section, who was not in labor, who had no concern for maternal infection, and who had her amniotic membranes ruptured at the time of delivery, well, that baby's probably at a pretty low risk of sepsis, even if they're grunting at birth. You can likely attribute it to something else. And they found that among extremely preterm infants, recognition of this differential risk can help guide decisions to limit early antibiotics in up to a third of these babies. So really, instead of having a multi-pronged approach, they basically split preterm babies into two categories. You're either low risk or you're not. And if you're not low risk, you're high risk. And so again, unlike those three approaches for term infants, the current goal here is really to draw a line in the sand about whether you're at the lowest risk or not. And for infants meeting the low risk criteria, again, these would be even a 24-week baby who was born because of maternal preeclampsia, who mom never had labor, never had rupture, never had fetal concerns, just was having issues with her blood pressure. And that baby's going to be sick at birth. Every 24-week infant is going to have respiratory distress. They may be intubated. They may need surfactant. They may need dopamine for their blood pressure. But can you comfortably say, this isn't sepsis. This is a baby who was born with really low-risk delivery characteristics. And this is what we're doing at my center. For infants not at low risk, infants not at low risk are automatically at high risk. And so if there's preterm labor, you're out. Preterm ruptured membranes, you're out. Any concern for maternal intraamniotic infection or unexplained non-reassuring fetal status, you're basically deemed high risk, and the most reasonable approach is to start antibiotics. Again, keeping in mind, remember in the beginning, that differential incidence rate between infants and preterm. So the stakes are just much higher. And so these criteria work pretty well. This is what we've been doing at my center for a couple years. This is a study published by one of my colleagues. Our high-risk level 3 NICU, we have 50-bed level 3B NICU, about 5,000 deliveries a year. And we started a guideline on empiric antibiotics for preterm babies, and basically said, these are the babies who you can comfortably not start antibiotics on. And it's a guideline, it's not a mandate. So if a baby's born in the setting of preeclampsia and they're dying in front of your eyes, absolutely start antibiotics. But if you feel comfortable that their illness can just be attributed to prematurity, then you have some data to back you up in not starting antibiotics. Early antibiotic initiation decreased among low-risk VLBWs, which are very low birth weight infants, from 62% to 13%. And the incidence of confirmed early infection, death, or transfer in the first week were unchanged. Again, this is just one center, but we wanted to look at this more closely and even expand upon some of these criteria. And so we added a couple because the NRN data just have some limitations. It's really hard to define labor. I don't know if there's any obstetricians in the room, but Labor is not just a yes or no phenomenon, and so in large data sets like the NRN, you really can't have a variable for whether labor was present or not. Obviously, if there's a vaginal delivery, then there's labor, but just because you had a cesarean delivery doesn't mean there wasn't labor. And also the NRN made it a little bit challenging to determine if there was any acute unexplained non-reassuring fetal status. And so keeping this in mind, we designed a study using some data from our birth hospitals in Philadelphia to look at this closer. So a smaller N, but more granular data. And so this is a secondary analysis of a study done from 2009 to 2014 at 2 of our birth hospitals in Pennsylvania, about 10,000 deliveries a year. And we looked at infants of all gestational ages, so not just preterm, who had a blood or CSF culture drawn in the first 72 hours. And we looked very closely by detailed chart review and data abstraction at their delivery characteristics. And our primary outcome is early onset sepsis, and our secondary outcomes were initiation of empiric antibiotics, and then the duration of antibiotics if started. And for duration, we looked at it as both a continuous variable in hours, and then also as prolonged versus not, which we defined as greater than 72 hours or not. So we identified about 7,500 infants who had a blood culture or CSF culture drawn. Again, this was all gestational ages, not just preterm. And we split them into not low risk and low risk. So again, the low risk babies were born by cesarean delivery, no labor, ruptured membranes at the time of delivery, no concern for maternal infection or chorioamnionitis, no concern for acute unexplained fetal status. So like a very, what I would call clean C-section or cold C-section. We've identified 41 cases of early onset sepsis during this period, about 0.6%, and no infant with early onset sepsis was born in the setting of these low risk delivery characteristics. All 41 cases had at least one of these concerning risk factors. These are just some selected clinical characteristics between the low risk and not low risk infants. Basically, babies who are in the not low risk or who are in the low risk category were often born premature at lower gestational ages and lower birth weights. And this makes sense. Why are babies born premature? Well, about half are probably just idiopathic preterm labor. The other half are because of maternal condition, either maternal illness, most often maternal preeclampsia, and high blood pressure. This table shows the proportions of uninfected infants in each group that were started on antibiotics. So we took out the babies who actually had infection. And we looked at their rates of antibiotic initiation. Did they get started, yes or no? Were they prolonged, more than 72 hours or not? And then the duration of antibiotics. And we adjusted for some potential confounders. And we found that the low-risk infants had a lower odds of antibiotic initiation. So providers were actually, they were seeing this. They were making decisions that babies who were born low-risk maybe didn't need to be started on antibiotics. But among those started on antibiotics, there was no difference in the adjusted odds of prolonged antibiotic duration or the duration in hours. So essentially, low-risk characteristics were not associated with a shorter duration of treatment. So clinicians may identify infants at the moment of birth who are lower risk, but once they made the decision to start antibiotics, even in the setting of a sterile culture, they did not take this differential into account. So to summarize this study, we identified a well-defined subset of infants at all gestational ages that are at the lowest risk of early onset sepsis and may be spared empiric or prolonged antibiotic exposure, regardless of infant clinical condition. And so the implications here include potential adjustments to sepsis risk assessment in term infants. Are there some babies you don't even need to do the sepsis calculator for because you just know their risk is going to be so low? And then also confirmation and enhancement of these prior studies that identify a subset of lower risk preterm infants. And so back to the risk assessment for preterm babies, the field is now moving towards identifying infants who aren't in this very clear low risk category and who aren't automatically higher risk and maybe are somewhere in the middle. And so I'll briefly mention 2 ongoing studies that are trying to help identify this middle group, because we are still starting the overwhelming majority of preterm infants on antibiotics. This has just made a small dent in that. So the NANO trial, this is an ongoing study in the Neonatal Research Network. It stands for NICU Antibiotics and Outcomes. The birth hospital I primarily practice at is a center. And this is meant to be a multi-center placebo-controlled trial of around 800 extremely low birth weight infants, so born weighing less than 1 kilo. This is a pretty big deal. I have never seen an antibiotic trial in the NICU. There just aren't many. And so most of the practices we do are not actually based on any trial data, which is the gold standard. Their hypothesis is that the incidence of adverse outcomes is higher in babies who received early antibiotics compared to those who received placebo. But this trial really targets that middle group. So you're not the babies who are clearly at very low risk of early onset sepsis. You're not the babies who are very high risk, so preterm labor and maternal fever and chorioamnionitis. You're somewhere in the middle. So maybe at 32 weeks, mom went into labor, but it wasn't clearly infection. We just didn't really know why. The outcomes here were late onset sepsis, necrotizing enterocolitis, and death. And the reason for late onset sepsis and necrotizing enterocolitis is there's this thought that early exposure to broad spectrum antibiotics disturbs the preterm microbiome, especially in the gut, and can predispose to later infection and also necrotizing enterocolitis, which has been shown in a couple studies. They also looked at antibiotic days to full feeds, retinopathy, BPD or chronic lung disease, and growth. The study's ongoing, and it has had very slow enrollment. I think in 2 years at Pennsylvania Hospital, we've enrolled 1 newborn. I think the issue is that there's actually not that many babies that fall into this group as we anticipated. So when you think about preterm deliveries you attend, many are either because of maternal health indications or because of things like prolonged rupture or concern with maternal infection. And then also, I think there's definitely some provider hesitancy. So as a neonatologist, are you comfortable enrolling a baby who's on the ventilator and on dopamine into a study where they're getting antibiotics or placebo? And it just appears that providers and parents aren't so comfortable doing that. One of my colleagues named Sarah Coggins, this is her master's thesis. She's trying to phenotype babies for early onset sepsis risk assessment. So try to look at all different types of variables, including the exact indication for preterm birth, the mode of delivery, the labor type, the duration of rupture membranes, to try to develop some categories or phenotypes to help us make easier decisions. So instead of having this be a binary high risk or low risk, could we actually make this a little bit more granular by looking at the underlying indication for and the mode of preterm birth? And maybe that can substantially modulate our baseline early onset sepsis risk. And this work is ongoing. All right, I'm going to switch gears now and talk about treatment. So the 2 questions I want to address, and I get asked this a lot. First, given these evolving risk assessment strategies, are we actually treating less babies with antibiotics? And number 2, in light of antibiotic resistance concerns, which I'll talk about, should we still be using ampicillin and gentamicin? And is that the regimen that's being used in the birth centers here routinely? Yeah. Amp and gent. That's what we use too, and that's what the AAP suggests. The AAP says that ampicillin and gentamicin remain the most appropriate routine empiric antibiotic regimen for both term and preterm infants at risk for early onset sepsis. This is from the 2018 guideline, and from what I understand, they're about to reaffirm this 5 years out. So first, let's just talk about antibiotic use. This is actually where most of my research is focused, on antibiotic utilization in the NICU. I use a database called Premier. We analyzed over 1 million inborn NICU admissions from 2009. We actually extended this to 2021 to determine the proportions of infants who received at least 1 dose of AMP or GENT. And again, these are babies just admitted to the NICU. The relative proportions actually decreased by 1/3, and this continued through 2021 in our recent data update. And there was a significantly decreased annual absolute difference for both drugs. And you can see how both were starting to decrease slightly, and then around the time where the sepsis risk calculator work was published and the AAP updated their guidelines, they really started to drop. And so this obviously isn't a direct measurement of the effect of the sepsis calculator, but if you're using it at your centers, I think you can probably agree that it's had a pretty big impact on the proportion of babies we're starting on empiric antibiotics, especially those born older. But when we looked specifically at the extremely low birth weight infants, the rates were not as impressive. This is over 30,000 ELBWs, so a very large number. We found that the proportions receiving Ampingent did decrease slightly between 2009 and 2019, but only minimally. And we followed this out again to 2021, and the pattern hasn't changed much. And so more than 80% of extremely low birth weight infants are still receiving these drugs. We were also interested in how the shortage and subsequent discontinuation of cefotaxime, which is a third-generation cephalosporin, impacted antibiotic choices in the NICU. Note here that the y-axis only goes to 30%. So the blue line is all NICU infants, and the green line is extremely low birth weight infants. Again, just babies admitted to the NICU. And you can see that for all NICU infants and for the ELBW infants, cefotaxime use decreased dramatically after 2014. This is not shocking at all. The US FDA discontinued cefotaxime after 2014. And if you read the FDA announcement, it's not because of any safety issues. It's a little bit vague. And my takeaway is that it was because of financial reasons, that pharmaceutical companies weren't making money off it. NICUs are the only ones, and maybe PZR is the only ones using cefotaxime. So it's not produced in the US anymore. Do your centers have cefotaxime?
I recently got a notice from the pharmacy saying that they were thinking of taking it off formulary, and like, wait a minute, you mean we have it? We could have been using it. And like,
yeah,
oh, yeah,
so
we do.
many centers will still, and I put my little shout out to Justin Trudeau, so many centers will still buy it from Canada. So centers that were not willing to give it up, you can import it from Canada. And other centers across the world do still use it, but most centers in the US don't use it anymore. You can see how we went from 25% of extremely low birth weight infants being exposed to cefotaxime to less than 5% in just a decade. What about broad spectrum antibiotic use? So we looked, this is for the extremely low birth weight infants, at drugs like ceftazidime in green, which is another third generation cephalosporin, which actually has a broader spectrum than cefotaxime. And also it's cefepime in yellow, which is a fourth generation cephalosporin, provides pseudomonal coverage. Piperacillin-tazobactam, which is Zosyn in blue, and then meropenem on the bottom. So broad spectrum antibiotic use is increasing among extremely low birth weight infants. Note here that the axis goes to 20%. Cefepime use in yellow tripled, and ceftazidime use in green doubled during the study period, both with significant annual changes. And I speculate this is because of the unavailability of cefotaxime. So this is just what folks are using in its place, which is a shame because, again, ceftazidime is broader spectrum, and cefepime is a really broad spectrum drug. And multiple studies suggest early exposure of these drugs in preterm infants drastically increases their risk of not only necrotizing enterocolitis, but also invasive fungal infections. Basically, you're wiping out their developing microbiome and you're letting the bad things grow. Pip/Tazo use also increased. I'm not quite sure what to make of that, except that I think that our resuscitation of infants at periviable gestational ages has increased, and that's probably attributable to some more surgical or neck-related cases. At Pennsylvania Hospital where I work, we're almost routinely resuscitating as early as 22 weeks. Luckily, meropenem use, which is one of our biggest guns, has remained quite stable, but still 5% of ELBWs are exposed to this drug. Just to talk a little bit about globally which bacteria are associated with antibiotic resistance. These are the main players, and you will see that number one is E. coli. E. coli is the leading bacteria globally for deaths associated with antibiotic resistance. So this is concerning, given that I told you earlier that E. coli is the most common organism causing early onset sepsis in preterm infants, and number two for terms. And so this really requires careful surveillance. I'm going to pause here and just play this video to demonstrate how quickly bacteria can develop antibiotic resistance.
So what we ended up building was basically a petri dish, except that it's 2 feet by 4 feet. And the way we set it up is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish thick agar with different amounts of antibiotic. On the outside, there's no antibiotic. Just in from that, there's barely more than the E. coli can survive. Inside of that, there's 10 times as much, 100 times, and then finally the middle band has 1,000 times as much antibiotic. And then across the top of it, pour some thin agar that bacteria can move around in. The background is black because there's ink in it, and the bacteria appear as white. First, you see they spread in the area where there's no antibiotic, up until the point they can no longer survive. Then a mutant appears on the right. It's resistant to the antibiotic, it spreads until it starts to compete with other mutants around it. When these mutants hit the next boundary, they too have to pause and develop new mutations to make it into 10 times as much antibiotic. And then you see the different mutants repeat this at 100. And after about 11 days, they finally make it into 1,000 times as much antibiotic as the wild type can survive. And so we can see by this process of accumulating successive mutations that bacteria, which are normally sensitive to an antibiotic, can evolve resistance to extremely high concentrations in a short period of time.
So what fascinates me about that video is that bacteria have been here for a much longer time than us, and they're much smarter than us. E. coli replicates about every hour and a half. And so when you are colonized like we are, millions, billions, maybe trillions of E. coli, and you dump broad-spectrum antibiotics into the system, they will learn and they will evolve. And so because of these concerns and help us inform antibiotic choices in the NICU, we designed a study which sought to determine the epidemiology and antibiotic susceptibility patterns of E. coli among a large sample of NICUs. This was a retrospective study from 2009 to 2017, community and academic NICUs, and we identified infants in an administrative database called Premier who had an E. coli infection using microbiology data, so not ICD codes. These were babies who had blood or CSF cultures or even urine for the later cases that identified E. coli, so true infections. And we found 721 babies who had an E. coli infection and who had available antibiotic susceptibility data. And these came from 67 NICUs across the US. About 2/3 were resistant to ampicillin, which has been the national trend, probably more like 80% now. 15% were resistant to gentamicin. That's a bit new. If you look at neonatal data from Yale and from other centers who have been tracking this for a long time, from 2000 before, it was 0. There was 0% resistant to gentamicin. 0% were resistant to carbapenems. That's really reassuring for the moment, although that's not been the trend in other places, especially low and middle income countries. And that was really the only drug class where we found 0% resistance. 5% of these E. coli had an ESBL phenotype, which basically deems them resistant to cephalosporins. We looked closer at the resistance for just the blood and spinal fluid, not urine, for isolates in the first 3 days after birth. So these are really early onset E. coli infections. And we found that, sorry, the font here got a little funny, but 10% of early onset E. coli was resistant to both ampicillin and gentamicin, and the rate of combined resistance was increasing over time. The amp and gent resistance really tracked with gent resistance, so if you were gent resistant, you were most likely to be AMP resistant as well, if that makes sense. Rates of ESBL did remain low, but were slowly increasing over time, about 5%. And we did not, again, identify any meropenem resistant or carbapenem resistant E. coli. So I just told you that E. coli is the #1 cause of early onset sepsis in preterm babies, #2 in term babies, and 10% of early onset E. coli are resistant to both ampicillin and gentamicin. And so you may be asking, why is the AP then still recommending AMP and gent? And so I just want to go through a little demonstration, not really with math, but more pictorials to help put this in perspective. So for all newborns, the incidence of early onset sepsis, I said, is about 1 in 1,000 based on some data I showed you earlier. E. coli accounts for about 1/3 of cases. And like I said, 10% are resistant to AMP and gent. Sorry about the funny font here. For very preterms, the incidence is almost 14 per 1,000. E. coli is about half of cases. And also 10% are resistant to AMP and gent. So sort of some background numbers for these pictorials. So to show this visually, this is 1,000 newborns of all gestational ages. About 1 will have early onset sepsis. About 1 in 4,000 will have early onset sepsis due to E. coli. So at my birth center, we have about 5,000 deliveries a year, so we'll maybe have 1 early onset E. coli case. And 1 in 30,000 infants will have early onset sepsis caused by E. coli that's resistant to AMP and gent. So this kind of just helps you put it in perspective where that 10% sounds scary, but when you're thinking about the actual incidence data and the microbiology data, and then the resistance data, the numbers actually become quite small. The visual for preterm infants is quite different, and so this is very preterms. I said before that about 14 in 1,000 will have early onset sepsis. About half of those will be due to E. coli, and 1 in 1,000 in yellow here will have E. coli resistant to AMP and gent. But keep in mind, we're treating 800 in 1,000 very preterm infants with antibiotics. And so the question here becomes, what's your risk tolerance? Are you willing to accept that either one baby in 30,000 is going to have inadequate empiric early coverage, but you're going to give all the rest something broader? And does that differ for preterm infants, where the numbers aren't as striking, but still you're going to be treating 800 out of 1,000 with antibiotics, knowing that only 1 is going to benefit from that broader spectrum regimen. But I do want to pause and make it clear that that 1 in 30,000 is still someone's patient, it's someone's child, and unfortunately that patient is probably at risk for poor outcome. Even though we don't have great data to suggest that, most studies, the numbers are just too low to really assess a difference about if you have early onset sepsis from a resistant organism and had 24 hours of the wrong drugs, does that make a big difference in your outcome? We don't know. It probably does, but we don't know for sure. And the AAP does say that some babies should have broader coverage. They don't completely specify who they are and with what drugs. And so to help answer these questions, we did a secondary analysis of the NRN data I shared earlier. Again, this is 2015 to 17, 18 academic NICUs. And they identified 235 infants with early onset sepsis. And we basically wanted to develop an early onset sepsis antibiogram and estimate AMP and gent resistance for all pathogens, not just group E. strep and E. coli, which is what they did in the primary study. And then try to identify which infants are at risk of early onset sepsis that would not be optimally treated with AMP and gent. So to answer these questions, we basically looked at each isolate and the available susceptibility data. They weren't perfect, so susceptibility data are really hard to capture. Even in electronic format, not every center tests for the same drugs. Not every bug is tested against every drug. And so we did the best we could. And we found, or we estimated that about 8% of the isolates would not have been adequately treated with AMP and GEN. And this is based on the actual susceptibility data and then some assumptions based on microbiology principles. The concerning thing here is that unless you treat a baby with more than 5 drugs, you're never going to cover every bug. And so the addition of a carbapenem would provide coverage for all of the E. coli, essentially, and also MSSA isolates, or methicillin-sensitive staph, but only if you added vancomycin, carbapenem, an antifungal agent, and still kept AMP and GEN, would you have adequately covered all 239 isolates. So there's a trade-off here. Are you willing to accept that most of the babies you're treating will be adequately covered, but not all of them? Or are you going to slam every single baby with 5 broad-spectrum drugs? And where do you draw that line? Again, although prior studies suggest that very preterm infants born in the setting of PPROM or preterm prolonged rupture of membranes, or with substantial exposure to maternal antibiotics, so these are the women who show up at 28 weeks ruptured and who sit on the labor floor for 4 weeks, get 2 weeks of broad-spectrum antibiotics, they're probably at the higher risk for antibiotic resistance based on studies and also just based on what we know about antibiotic exposure. We did not find a difference, again, in mortality between the babies who were infected with bugs that were probably optimally or adequately treated versus not. But I suspect this is because of the small sample size, and also there's a high baseline mortality risk for early onset sepsis. So if many of the babies with early onset sepsis are dying, can you really determine a signal between those who are adequately treated versus not? So how do you balance these risks and benefits of something like AMP and GEN versus a broader regimen? And when I say broader regimen, folks are doing this. I moonlight at one of our community hospitals in the suburbs of Philadelphia, and they started treating all preterm infants with ampicillin and ceftazidime instead of gentamicin. Some centers are doing AMP, GEN, and ceftazidime. Some centers are giving all preterm babies Zosyn after birth, or cefepime. So there's definitely some creep away from AMP and GEN. All it takes is one case of a baby born with a resistant E. coli to change your practice. Again, AMP and GEN covers about 92% of early infections. It involves less risk, although AMP and GEN is still a fairly broad spectrum regimen. And you're giving it to the majority of babies who are uninfected. But the infants with a resistant infection will initially suboptimally be treated. And again, you can imagine that will lead to worse outcomes, although the data are inconsistent there. So with broader coverage, something like a third or fourth generation cephalosporin or piperacillin tazobactam or carbapenem, you could cover more, but then you're exposing those babies, especially the preterms, to the risks of broad spectrum antibiotic exposure. And again, the majority of them are going to be uninfected, and those risks include necrotizing enterocolitis, invasive fungal infection with candida, and more. I'll say it again, there's no perfect empiric regimen which will cover all identified organisms unless you're using 5 drugs. And keep in mind that units with more broad spectrum antibiotic use have more antibiotic resistance. And so if you're giving preterm babies broad spectrum antibiotics early in life, they're going to develop antibiotic resistant infections later on. We can't ignore the fact that broad spectrum antibiotic use will lead to more antibiotic resistance and ultimately more infections with less treatment options. This is a daily reality in many neonatal units across the globe, where they have gram-negative infections in their NICUs or among newborns that are resistant to every available drug or nearly every available drug. And we see case reports about using drugs that I've never even heard of before or that I've never prescribed before that are definitely not on our formulary from the adult world with 0 data to try to treat these infections that are resistant to cephalosporins and carbapenems. And we know from other antibiotic resistance pathogens that this is coming our way. So in the next 10 to 20 years, with increased global travel, with ongoing antibiotic resistance and antibiotic use, we will have babies in our NICUs with carbapenem-resistant gram-negative infections. and most certainly cephalosporin resistance. And for cephalosporin resistance, we're seeing that already. So again, some babies should have broader coverage. The AAP statement for term infants from 2018 states that among those who are critically ill, empirical addition of broader spectrum therapy should be considered until culture results are available. That's a little bit vague. I think they did that on purpose. You know, even in my institution, people think that my boss and I are the antibiotic police, but if I come in and there's a baby who's literally dying, a full-term baby who's dying, who's on epi and dopa and the oscillator and 100%, and if they're just on amp and gen, I would be the first one to throw something else at them. That baby is a totally different scenario than a well-appearing baby in the nursery. It's trickier for preterm infants because preterm infants are inherently ill at birth. And so we can use those risk factors like prematurity, prolonged ruptured membranes, or maternal antibiotics to maybe help us decide to start antibiotics or more broad spectrum antibiotics. The AP does not say what they are. And so that will be up to your local antibiogram data. Most likely it will be a third or fourth generation cephalosporin. So again, for now, AMP and GENT remain the most appropriate routine empiric regimen for both term and preterm infants at risk for early onset sepsis. I anticipate this guidance will change. I'm hoping that it won't be broad spectrum for everyone, but maybe instead we can do more individualized risk assessment, not just for whether or not you should start antibiotics, but which antibiotics you should start. I'll end there. Sorry, I'm just about almost at time. Thank you so much again for having me. This has been a real joy to come back down to Southwest Virginia and to speak to you all, and I'm happy to take any questions.
In what you've described here, you described characteristics of maternal risk factors. Do we have any maternal placental culture data to add into this?
Yes, that's an excellent point. That often gets forgotten. Many centers send placental pathology routinely. Other centers, it's at the discretion of the obstetrician. There's a lot of practice variation there. Placental cultures can be helpful, but they're not going to be helpful in that period I'm talking about where you're deciding whether or not you need to start antibiotics. They may be helpful if maybe the baby was sick and you gave antibiotics before you could get the culture, then maybe you can rely on the placental culture. But at least in my experience and from what I understand about the data out there, many of the placental histology findings of chorion neonitis are non-specific to infection. So unless they identify an organism, it won't be that helpful. And unfortunately, that information will probably come later. So I think there is a space for it, but probably not in that antibiotic decision moment soon after birth. Yes.
So just thinking longitudinally about this, you were talking about NEC, late onset sepsis, but what about at age 4 and 5? Are there any, like from these early exposures to antibiotics? Probably not out there, no data, but is there anything that speaks to that?
Yeah, there definitely are for the term population, and so there are some pretty solid data, again, all association data, not causation, that babies, full-term babies who are exposed to perinatal antibiotics, and much of the data is not even focused on babies who got antibiotics, it's mothers who got intrapartum antibiotic prophylaxis. So mom is colonized with GBS, she comes in for labor, she gets antibiotics during labor. That alone has been associated with adverse outcomes in term babies, specifically differences in weight, so higher weight, increased risk of autoimmunity or allergic diseases. And specifically for weight, the difference is subtle. It might be half a pound at age 5 or something like that. But the signal's pretty consistent across many studies. Multiple studies outside of the NICU world that antibiotic exposures during infancy, and in the US, infants and toddlers receive about 2 antibiotic prescriptions per year, are associated with dysbiosis, increased BMI, increased risk of wheezing, allergic diseases, and some weaker data on autoimmunity. I think for preterm infants, we're not there. I don't think have looked very closely at antibiotic exposure and later risk, namely because we're all getting antibiotics, so it's hard to really distinguish that.
Any comments on probiotics and their impact with your antibiotics, I guess?
Yes. probiotics are in the press recently. I don't know if anyone has seen that. The position on probiotics in the US, in my opinion, has been a little bit weak as opposed to other countries and in Europe. The data for probiotics in preterm babies and decreased risk of NEC are quite good. Many centers in the US are using them, many centers are not. My center is not. The AAP actually does not recommend them because the main issue is that because it's not a pharmaceutical product, that there's so much variation in the different strains and products that it's hard to pull the data together. I think we need to get over that and really figure out how to move forward. But then when something happens, like a baby develops sepsis from the probiotic strain and dies, that becomes national news, a black box warning goes out. That's terrible, and that's somebody's baby. But again, everything has risk. And so you have to decide, am I gonna use probiotics because I'm gonna decrease NEC and death in a lot of babies, or am I not because there's gonna be that one baby who will get sepsis from the strain? I think that's going to be a roadblock for probiotics in the U.S. It all depends on your philosophy because no treatment is perfect and every treatment has risks. But I don't know why we're so focused on probiotics with those risks and we don't for other things. So for the neonatologists in the room, we use Indocin or ibuprofen to treat PDAs, which has no great evidence for outcomes and can be very harmful. Can lead to kidney injury, spontaneous intestinal perforation, bleeding, and we do it all the time. And we don't even have great data that it works or helps. So I'm more in the probiotic camp, but I've never actually prescribed one.
Thank you so much.
All right, thank you guys very much.